Thank you for watching this program tonight with the best physicians of the region. My name is Dr. Luis Munoz, and I'm the president of the El Paso County Medical Society. It is our hope that you will find this program informative and interesting. We at the El Paso County Medical Society invest in community education with our programs. I hope you'll find this program very informative with great medical advices and great medical information. Thank you again for watching this program tonight, and have a great night.
Big hearts versus small hearts. Physiologically, they're very different. Pediatric cardiologists diagnose, treat, and manage children's heart issues very differently than adults. Surgeries on children's hearts can be very intricate and very specialized. Pediatric cardiology is a growing need in the borderland, and today we're going to be focusing specifically on structural heart disease. This evening's program is underwritten by the El Paso Children's Hospital, and we also want to thank the El Paso County Medical Society for bringing this program to you for 28 years now. I'm Catherine Berg, and you're tuned into the El Paso Physician. Thank you so much for joining us. Today we're talking about pediatric cardiology and that it's such a growing need in the borderland. We have Dr. Schuster with us, who's been with us in the past, and I feel like I've known him for 30 some odd years. But Dr. Jeffrey Schuster is the pediatric cardiologist and chief medical officer for the El Paso Children's Hospital. Thank you so much for being our veteran and for being here today. We also have Dr. Muhammad Asif Qureshi, who is a pediatric cardiology as well. And we are going to be speaking a lot about the little ones and how treating little ones is so different than treating the big guys. So on that note, Dr. Schuster, if you could talk about a little bit so the audience can get to know you a little bit. So yes, you're the chief medical officer for the El Paso Children's Hospital. What a job. But in general, how did you get there? How long have you been doing cardiology? Are you an El Pasoan, et cetera?
So I was born and raised here in El Paso.
Nice, I love hearing that.
Went to all the local schools here in El Paso, went off for college in Louisiana, back to San Antonio for medical school, Galveston, Gainesville, Florida, Chicago, and then back to El Paso 37 years ago.
Oh my goodness.
So I've been here longer than I've been away at this point. For a while it wasn't that case. But I've been trying to take care of all the hearts that we have here in El Paso. So it's kind of funny at times when I tell people that I'm a pediatric cardiologist, some of them think I take care of little baby heart attacks. And heart attacks are extremely rare in pediatric cardiology.
Right.
They do occur, but it's not something that we take care of on a day-to-day basis. So,
and we'll talk about how things really began. And I love, we were talking a little bit prior to the program beginning, we are going to speak specifically about babies even before they're born.
Right.
And how you look at specialized ways of helping even prior to that. Dr. Qureshi, so let's talk about you. You are a pediatric cardiologist, and you are, my goodness, you were just giving me all kinds of notes. For the audience here, this is what my notes look like, and we haven't even started yet. And there's just like chicken scratching everywhere. So I very much appreciate that because it helps me prep, even on top of the prep we've had before coming here. Mm-hmm. So in general, what is your background?
Well, I just want to first say thank you, Catherine, for having us here. This is a good platform to let the people know that what we do. I have done my medical school back home in Karachi, Pakistan. Mm-hmm. And I moved about 32 years ago here in the United States. I've trained in New York with the New York Medical College for my pediatric residency training program. And after that, I did almost like a, not going to believe, but I did like 9 years of general pediatrics. And after that, I went into a pediatric cardiology program from 2005 to 2008.
Okay. So you do big hearts and little hearts.
Well, I did a pediatrics, so, big hearts, not that interesting, but small hearts are really, it's really challenging, because they're born with situation and conditions, that they are not I mean, this kind of big puzzle to solve.
Yeah.
So I started my cardiology career or pediatric cardiology career here in Texas. So my first destination was all the way in the Panhandle with the Texas Tech University in Amarillo, Texas. I spent like 4 years over there. Then I moved to Baylor Scott and White, which is now it's Scott and White is now called a Baylor Scott and White, and I spent like almost 4 or 5 years over there. And after that, I ended up, so as you can see that I was in up north, and then I was in the middle of Texas, and I ended up in McAllen, which is all the way south. That was honestly like a great experience over there working at the border with the private practice, which is a little bit of different practice, like we practice in the big institutions.
Right. And now you're here at El Paso Children's. So welcome to El Paso. We're very excited to have you here.
Thank you so much. I'm so excited. I started like in November of last year.
Great.
And I met with Dr. Schuster, obviously. He knows the whole history of El Paso here. I need to sit down with him sometime.
I love
to
that.
learn all that kind of history, learn that, pediatric cardiology history from him here. So I think the main thing which is kind of excited for me to be here, because I've been most of the places, that it is like a little bit more challenging here at this point.
And why is that, would you say?
I would say it's not, there are like, it's a border town. That's one thing. I did work on the border town before. So sometimes you come across to the diseases which were not diagnosed way before, So they cross the border, they come to us, and sometimes the diseases were supposed to be diagnosed way earlier, then we diagnosed them right here. And then the border patrol, like they bring the kids and all that, we diagnosed like not, I think I would say like maybe 2 weeks ago. We had an interesting 3 years old, and they called me from the emergency room. He was stable though, but we did have a very rare kind of a condition in that child. We made a diagnosis, the child was stable, and the final destination was in California.
And what was that condition? Are you able to speak about that? Okay.
Yeah, absolutely. So sometimes as I said, it's interesting. So sometimes they're born with, like if I would like you to just to show from this model, is that okay?
Sure, since we're on that topic, and then we'll start with the very beginning of babies in the womb. But since we're on that topic, sure.
So what happens that the lower two chamber, they kind of twisted. So instead of this bigger artery, we're supposed to come out from the left lower chamber. I just wanted to show you.
So the cameras can see it.
So as you can see that, let me just see if I can take this thing off. This is kind of magnet. So
there you go.
It's easily breakable heart, so just want to let you know so we can.
It's a male heart. Male hearts are very much more delicate than female hearts.
Oh, look at you. I kind of love everything about that. They are, aren't they?
Well, that's for Dr. Schuster's opinion, so. But I wanted to let you know that these two lower chambers, I wanted just to, so if you see that these are the two lower chambers, they are mainly the pumping chamber, we call them, or the ventricle in medical term. These pumping chambers, so the left one is the one which actually push the blood up into this bigger arteries called aorta, which supply all the good oxygenated or oxygen-rich blood to the body. And the right side, when it comes back to the right side push the blood to the lungs. So the lungs is like a grocery store for oxygen.
Right.
So we get the grocery done, oxygen thing, it goes back, come back to the left upper chamber, goes to the left side. And that particular child, which I just want to let you know is that...
And give me the age, so it just gives us perspective on the age of this child, más o menos.
He was like 3 years old.
Oh, so little. Okay.
Yeah, he was 3 years old.
Okay.
So what happens that he was not diagnosed because his... those two chambers kind of swapped. So the right side actually, left side went to the right side, left side went to the left side without any change with these two bigger arteries which supply the blood to the lungs and to the body.
So this was a
It's
congenital issue, so something he
congenital,
was
yeah.
born with.
There is a
Okay.
name for that, so we
Okay.
call it a congenitally corrected
Okay.
transposition. Means like
Makes
it's
sense.
transposition of the great arteries.
Right.
This is the
Okay.
name for that.
And how is the diagnosis performed? Like what kind of a procedure? He's having what symptoms, for example? What are his symptoms? And then how do you figure out what tests you need to perform to diagnose
Absolutely.
him?
Well, that's a great question. The thing is that, as you can see, that he was there and he was diagnosed. I think he was. I don't know which country he was from. I'm not recalling that. But he has some kind of a diagnosis, and he was told. The mother was told that, hey, you can just provide as much love as you can to the child, because this child is not going to, live very long. He's going to need a new heart and things like that. So mother was so stressed out.
And what were his symptoms? Was he having a hard time?
Yeah, he was
breathing?
when he actually came to the emergency room. I think there was a complaint of a little bit of a shortness of breath
Okay.
and stuff like that, which was not related to the underlying heart condition. It was most likely that he was in a place where it was crowded. So he had that kind of feeling. So they ended up, the only time we make a diagnosis, when they called me and they said, hey, we wanted to have an echocardiogram done on this child because he had a prior history of some kind of a heart condition, and mother
Okay.
was told that he's not going to live very long.
Okay.
So when I saw the echocardiogram, and it was like a quick, because you see all the morphologies of the different part, it was like, it didn't take very long to make a quick diagnosis of that.
And if you can explain to the audience, what is an echocardiogram? Like what
Yeah,
is happening
it is
within
like
that test?
it is more like an ultrasound, like the people have an ultrasound. So it's like the sound wave. When we say ultrasound, it's like the sound where you cannot hear it.
Right.
So those sound waves actually goes and it's make kind of different kind of a pictures. In our case, when we do like it's the same thing. It's like echocardiogram is the same. Like it produces the same kind of a sound waves. It goes there,
Okay.
and then it comes back, reflected back, and then it make like image right there, and we can see all that image. We see the color flow. It tells us where the blood is flowing, which direction.
Right.
And then we have the other ways to check how fast it is going, how slow it is going, and all that.
Okay.
So that's what it is. And I was glad that I actually had a good time with that mom, and I explained everything very well, and she was happy. And I told her, well,
Now we know
this
what's
thing,
happening.
Exactly. Yeah.
Excellent.
We can get
So,
a
Dr.
diagnosis
Schuster. Yes, sir.
with echo in almost all of our patients.
Nice.
So
okay.
before there was ultrasound, we had to do some very dangerous procedures. Now we're talking 30, 40, 50 years ago. But the echocardiogram really provides a diagnosis almost always.
Okay. And I love how you're talking about that. So we're talking about echoes while the child is already a child. Not that they're not already a child, but I do want to focus on what we talked about prior to the show is when in utero, when the child is yet born and there is an ultrasound, a sonogram that's sometimes just normally done, that there are ways that you can find structural issues in those cases. So I'd love for you to start, because I know that you talked about this earlier, and I was just fascinated just listening to you talk about how old in the womb does a child have to be to find something wrong? I mean, if we're looking at a couple of months, we're looking not until 5, 6, 7 months. Kind of take it from there.
So first we can discuss, well, why would we look at a fetus's
Right.
heart? So there are some really good indications to do that. If mother was born with congenital heart disease, she has a substantial risk of passing that on to her kids.
Exactly. Okay.
Despite what I said earlier, the father is not unimportant, but he's less important. Siblings are also a very big indication. If anybody in the first-degree family has congenital heart disease, the chance of it recurring are worth looking for.
Okay.
Now, there are other things that we can also have to do. El Paso has a lot of women with gestational diabetes, and that is an indication to look at the baby's heart. Other things is sometimes the OBs can draw certain blood tests, and we'll get, concerning things there. So if we have those kind of indications, and well, the number one yield indication for a fetal echocardiogram is if the OB or the maternal fetal medicine doctor says, I think there's something wrong with this heart. Now, we get a very good yield on that. Gestational diabetes, you can do 50 and find nothing.
Okay.
But
And when would the doctor say, I think something's wrong with his heart? Like, what would be the indication
well,
of
so
that?
one of the things that they might say, I think this kid has a 3-chambered heart, and you're supposed to have 4 chambers.
Because they can hear that in the echo.
Well, so
or
they can
that
see
is,
it
so
on
they can
the
actually
echo.
physically see it too.
And they can say, well, and one of the things that we see is, for instance, in babies with Down syndrome, they'll have 1 valve instead of 2 between the upper and lower chambers. And they are very good at identifying that. So we have indications from the MFM, the maternal fetal medicine, or the OB doctor, and then we can go. Now, if we find something, that's really important, because the chance of dying, and I'll use that word
you have
acutely.
To. Right. Yeah.
Because, I mean, there are some lethal heart diseases at birth that can go home with mom. The baby goes home with mom. And you go, oh my God, how could this happen? Well, it does. And
now, when you say that it's not caught prior to the child be born,
right, the
is that what you're
baby
saying?
can, well,
Okay.
or even after birth.
Okay.
Now, you can't have a baby in America without having 2 ultrasounds.
Okay. Okay.
So we are catching more and more of it. But there are still, I mean, here in El Paso, we have mothers who haven't had any maternal pregnancy care. And so sometimes you get surprised.
And so you were talking about early, and I thought this number was quite startling. So congenital heart defects, you've got about 1 in 100, and you said it used to be about 8 in 1,000.
Right.
So that's up
So
quite a bit. Is that due to
it's up
diagnosis,
25%.
or is that due to actual issues?
Well,
Or both?
actually, I think the number has climbed a little bit.
Okay.
I mean, we went with 8 per 1,000 for the longest time, and now I'm quoting 1 in 100, which is 10 per 1,000. So we may be seeing more.
Do you think there's a reason for that? And I'm asking
Not that I
questions
can
that
put
should be
my
in the crystal
finger out,
ball.
yeah.
You know, that sometimes I ask questions that are not hypothetical, but wondering.
Yeah. Not that I can identify
Okay.
for us at this point.
Okay. And so when you're taking a congenital, so we've got a couple here that we were going to talk about in general, and we talked Kawasaki disease. So I feel like I've heard that here and there scattered around, but I'm not quite sure what it is. I think we've heard the word, but if you were to give that a definition for our audience
Well,
with congenital.
you are in good company.
Okay.
Because Kawasaki disease is an post-infectious inflammatory disease
Okay.
that we don't really understand completely. So if you say, well, what causes Kawasaki's disease? And we said, we have all sorts of ideas, but we cannot put our finger on it completely.
Oh, interesting. Okay.
So Kawasaki's almost always less than 6 years of age. High fever that just won't go away. You develop a rash, you develop changes in your skin, your eyes, your mouth, all sorts of things. And you have a high fever, and the blood work, which you'll have, if you've had high fever for 3 days, the doctor's going to order some blood work on you.
Right.
They will show very big inflammatory response. And unfortunately, like I tease the medical residents, is, well, just do the Kawasaki test. There isn't one. It's a clinical diagnosis of, you have 5 things, you need at least 4 of them, and then you have to have supporting stuff. So Kawasaki's is very important for kids under 6.
Okay.
Now, kind of interesting, another acquired heart disease, we are seeing some cardiac effects of COVID.
Yes.
So the
whole
problem
long
with
COVID.
Kawasaki's is they develop coronary aneurysms. I'll never forget the first Kawasaki's I ever saw was a 2-year-old who was bouncing off the walls. And when you looked at his EKG and you looked at his echo, he had had a heart attack. You know,
See, you don't think of aneurysms with children.
No,
It's just
you
not a
don't.
word, like you said, heart
Yeah.
attacks and aneurysms. It's
Right.
not something you think of with cardiology
But
or
with-
with children.
And in COVID, we're also seeing coronary problems.
Wow.
So again, it's post-infectious, but it's older kids. I mean, it used to be if somebody called me up and said, I have a 9-year-old with Kawasaki's, I would say, no, you don't. Nowadays, I pay attention to those because maybe they had COVID. A lot of COVID never gets diagnosed. And
So a lot of the
could that be-
presentation in Kawasaki's
Yeah.
and long COVID, the presentation's relatively similar.
So for long COVID, I was seeing quite a few patients in 2022 where they'd had COVID and they go to their pediatrician and say, he's tired all the time. He really can't get back into his physical activities that he did before COVID. Now, the good news is that most of those kids actually don't have anything wrong with their heart. And I would refer them to the pulmonologist because the pulmonologist actually will find some restriction in their lung function and things like that. But COVID, we now know, also causes a myocarditis, a viral infection of the heart that can be quite serious. Very
And that
rare.
would that, and this is a question too that would be different with every individual. How long might that last? Anywhere from a couple of months to a couple of years? Because we're talking several years at this
It's
point,
certainly,
correct?
I mean, it depends on the severity of the damage. There's probably damage that happens at a certain point. Usually there's not ongoing damage.
Okay.
But then you have the evolution of how the heart reacts to, well, part of the heart muscle is damaged. The heart does react to that. It tries to continue doing its best job despite the fact that part of the heart's not working well.
And the heart damaging, I think years and years ago, we did one of the first cardiology shows. They said a heart attack just means that there's a part of your heart that didn't get blood and it's dead. I remember thinking, boy, that's pretty drastic. But maybe you can explain when someone has heart damage, does that part of the heart ever get better?
Well, so that's why you want to be a kid, because kids heal better than adults do in almost all directions. And for instance, I'm doing it again, we have another cause for a heart attack in a kid less than 6 months of age. And if you fix what's causing that, I have seen kids, I can't tell there was ever anything wrong with them
Wow,
when they're
good.
5 years of age.
Okay.
And they have a scar from here to here, but they have recovered very well from Al Kappa.
Yeah, absolutely. I mean, I totally concur with Dr. Schuster about it.
Okay, so that throws something into the mix right here from Al Kappa. Explain,
Well,
what's Al Kappa?
Yeah, so when we have like a coronary arteries, the coronary arteries are the one which supply the blood to the heart muscles. So when we say Al Kappa, it means like an abnormal origin of the left coronary artery from the pulmonary artery.
Okay.
It's going to be good if I explain, through
Absolutely.
that, So
I love models.
Yeah,
And
so,
again, the camera's right over here, so feel free to point
yeah,
in that direction.
If you see that, I just want to let you know that the coronary arteries usually arises from right at the base of the bigger arteries right here, and they supply the blood to the heart muscles all over.
Okay.
They supply the blood to the heart muscles. And that's what we talk about the adult when they have a coronary artery problem, they have a loss of a blood going, and that's how they start with the heart attack.
Okay.
But it's different than what I'm talking about right now. So in pediatrics or in babies or newborn, they're born with the anomalies of the coronary artery, which means like that during embryology, what happens that the coronary arteries, they do not come off of this bigger artery. They actually kind of creep on. They just go towards that and kind of attach to that area. If they're normally attached, the baby's normal coronary arteries, if they go and abnormally attached, either to this bigger artery, which is called aorta, or one of them kind of make a little twist. And instead of attaching to the bigger artery aorta, it attached to this artery, which is actually supplying the blood to the lungs.
And is there a cause for that, or is that just something that's just the
Well,
makeup
this
of
is
that
something,
individual?
unfortunately, embryological.
Okay.
And even before the moms know, most of the time, then they are pregnant, the heart is completely formed. So it has nothing to do with like that the mother has done something wrong,
Right,
did not have
yeah.
enough, orange juice or
Yeah.
things and all that. Has nothing to do with that.
Right.
No one has to be blamed for that
Yeah,
because some
let's
of
not
the
even go
mothers and
there.
all that. I just want to let you know. So what happens is with Al Kappa, which I'm saying like anomalous means like abnormal, origin of the left coronary artery, which is supposed to be like coming from the left sinus right there, and it comes off from this bigger artery is called a pulmonary artery.
Okay.
With the period of time, and now this is the one when we can say that the babies can have a heart attack. Because once the baby is born, their pressure on the both sides of the chambers are almost equal. But with time, the lungs pressure decreases, and that's how this is like a natural way of doing it. About like 6 weeks to 2 months of age, all the pressures in the lungs is almost like ours pressure, like a normal adult pressures.
That's pretty quick. Okay.
So with that if you have the blood supply which is coming off not the normal but the abnormal bigger artery, when the pressure drops, the same time it's going to still happen. Instead of the blood going from the abnormal coronary artery to the heart muscle, is going back in there, to the lungs. So the baby start having like a heart attack.
Yeah, right.
They cry, but baby do cry, we don't know. Unless sometimes it happens to be like, for some reason the baby has a heart murmur and we check it, we saw, hey, this is like an abnormal anomalous origin. Or when the baby comes like around like 3 months of age, when they start having all that kind of what we call a congestive heart failure.
Right.
The heart can get
So you
bigger
hit on
in
something
size.
that I think is kind of interesting. So when we were talking about in the womb, about how many months in the womb is it when the heart is completely formed?
Well, the heart's pretty much formed within 6 weeks.
Within 6 weeks?
Within 6 weeks. We start doing fetal echocardiograms usually around 18 weeks of gestation. You can do them a little bit earlier.
Okay.
You can actually do a fetal echocardiogram at 6 weeks of age, but that's not on your abdomen.
Jeez.
So, and mainly you can see the heartbeat.
Yes.
You can't really get much
I'm just remembering when I was
definition.
pregnant, you can hear the heartbeat, but I didn't know that it was that quick. So when you're looking at that, then you really can almost diagnose. I mean, once you're able to see, I don't even know how I'm trying to ask that question.
We can see pretty much the entire heart on fetal echocardiogram. Now, for my patients, they always want to be on their stomachs so that I have to image through their back.
Oh, that's
So,
interesting. Okay.
Well, it's a complaint.
That's new. I
But you
was going to
can-
say, but yeah.
you can see pretty well. Now, there are some things that we go, okay, well, this is suspicious but not definitive, but we're
Right.
definitely going to do an echocardiogram
Okay.
after birth.
Okay.
Anytime I have any question about a fetal echocardiogram, I definitely tell mom and pediatrician, baby needs an echo at birth before going home so that we don't miss anything.
So if I'm going, I am going off script a little bit here. I know that you all are not surgeons. However, are there certain conditions, heart conditions, cardio conditions that can be fixed with surgery in utero? And
Yes.
and what are those? And again, I will throw the disclaimer out there. I know that you're not surgeons, but I'd love to hear a little bit about that because I just find that that's magic.
It is bleeding edge therapy. If you have, I mean, what you would do is you would see a baby that you say, this baby's not going to get big enough ever to survive. In other words, you're going to lose this baby before viability. I mean, if you're at 22 weeks with major heart disease and you deliver, there's not a whole lot that can be done. So, for instance, not actual surgery, but you can actually, for instance, if the aortic valve is severely blocked, you can actually try to open up that valve with a catheter through mother's skin, through the baby's chest, and open up that valve. Now,
That is amazing to me.
It is. It has associated risks for sure.
Of course.
But, I mean, you've got no survivals at all, and then you might have some survivals if you're able to get that valve open and things like that. Another one would be in a very malformed heart, if the upper wall between the upper chambers is intact, it will cause huge amounts of trouble and make the baby non-viable pretty quickly.
Okay.
So we can try to do things there. They have done actual surgeries. I mean, they have kept the baby connected to the mother through the umbilical cord, put them over here, do things surgically on them, put them back.
Oh my goodness.
And because mom's the best incubator we've got.
Of course. Wow, that's amazing. That's amazing. I feel like we can spend so much time on that. I do want to get to some issues with heart. You mentioned the word heart murmur, and I get it. You know, you say heart murmur in the old days, like, oh my God, they have a heart murmur. How many? I mean, a lot of people have a heart murmur. So let's first debunk the idea, if you hear the word heart murmur, that something's really wrong, and then go into palpitations, chest pains, fainting, etc. I mean, some of the electrical issues, because I always think about electrical issues with the heart, and I know I came in with that today. But if you could, Dr. Qureshi, talk a little bit about that.
Yeah, let's talk about the first of the heart murmur. So this is, I usually explain to the parents that this is like a kind of a whooshing sound, you can hear that. Now, heart murmur does not always mean that you have an underlying heart condition or hole in the heart and all that. But when I try to explain about the heart murmur, I would say like, let's say that there is a water hose, and there is you didn't put like a thumb in front of it, right? So the water is kind of streaming. The water is like a streamlined. It's kind of flowing okay without any turbulence, right? So you don't hear any sound. As soon as you put this finger right there, in front of it, you make like a little turbulence of this water, and any turbulence makes kind of sound. So basically, the heart murmur is kind of a turbulence thing. And now this turbulence can happen like inside of the cavities of the heart without having any kind of underlying heart condition or hole or valve or anything like that.
Chronic but benign.
So we call it exactly. This is a benign thing. But sometimes they have like a holes in the lower, especially with the lower, in between the lower two chambers of the heart, the wall there, and we call it ventricular septal defects, and those are the one. If you have someone born with really a big atrial septal defect, which just means that there is a big hole in between the upper two chamber, usually, you don't hear, but if you really concentrate, and I would say that maybe the cardiologist only can hear that sound, which is a diastolic type of a murmur, or flow murmur in the pulmonary area. If you can come back with, not with the other topic, like if you say that about from heart murmur to the palpitation.
Perfect. Let's talk about palpitations and arrhythmia and
right.
How
So
all those
palpitation simply means that it's someone have been like aware of his heartbeat. The awareness of the heartbeat is like we call a palpitation. Now, usually when we all run, we can be aware of our heartbeat, because we are running, we are exerting, we have our heart rate's going to be fast. But if someone is just sitting, not doing anything, do not have a fever, do not have any other problem, no anxiety, no upcoming test, and things like that, once they feel like the feeling of,
why is my heart beating so hard?
Is like, what
exactly.
is that, and that will be called. And then we wanted to investigate further to make sure that we are not missing any electrical problem of the heart.
Exactly.
So when we say electrical, this heart actually has electrical cables there. There are one generator, there is a second generator, one generator which generates electrical activity, the second one which kind of control the synchrony of that electrical activity. And the whole heart muscles actually everywhere, they are ticklish. They can produce electrical activities,
They're ticklish. I love that.
They are.
So
they are
marry
tickle,
that
yeah.
now with arrhythmia. So marry that now with beats that are missed or a couple of fast beats and then not another beat.
Yeah,
So,
when we say arrhythmia, it's just kind of like a misnomer. Arrhythmia means like a no rhythm. Obviously, if you have no rhythm,
Mm-hmm.
you're not alive, right? So more appropriate term, is like a dysrhythmia, the disturbed
Okay,
rhythm.
nicely
That I
said.
would just say. It's still we
Right.
use arrhythmia, but it's a disturbed rhythm. So it can be like extra beat. It can be like a skip beat.
And
It
is that
can
dangerous? Is that something people should look out for?
Well,
and I know, back and forth, whoever's listening, they're going to take that with every age. So, and would a
Absolutely.
child know to ask about that? Would a child know, hey, I'm skipping beats and it's a little bit fast and a little bit slow? So I'd like to kind of bring that into the forefront.
Absolutely. And then, I can tell you that the children, when they come, they're smart.
Good.
What they say, they usually don't say, my heart is beating fast or I have tachycardia. Those are the medical terms. They said, Doc, my heart beeps. My heart beeped. And you know exactly like a beep,
BEEP,
Yeah,
like a
yeah.
horn. Yeah.
Yeah. Like it's like that. And you need to figure it out, right? So we ask mothers and all that, wonder how often and how does it happen, when, and all that. And then we have those things we call an electrocardiogram. We do that. And in some instances, we need to do like a prolonged monitoring of that electrical activity of the heart. We have a certain monitors. One is like a Holter monitor we can use. We can use event recorder. And there are multiple others, and some of them, if you do not find it, believe me, that they insert like it right here, and it goes for a long time, like about a year, recording.
Right.
Under the
So
skin.
let's
Under
say
the skin,
let's
yeah.
say we do have a child now that has arrhythmia, and it's arrhythmia that's concerning.
Right.
From there, what is it that you all as cardiologists do to help, I don't know, bring that heartbeat back into rhythm? I know there's ablation. I think I've only spoken about that with adults. But in general, what is the treatment for a child that has pretty major arrhythmia that's
Right.
concerning?
So arrhythmias can be very serious. And we have medical treatments. We have medicines that can be taken by mouth, which are very good at controlling things, usually. But with all this white hair comes the huge amount of change that we have seen. So we used to have, I had kids, I had them on 4 medicines with some control. Not good control, but some control. And back then, that's all we had to offer, especially in a small child. Nowadays, I never have kids on 4 medicines anymore because I'll send them for ablation.
Oh, really? Okay,
Yes.
so that is an option for little
So
ones.
you can actually
Okay.
ablate a newborn.
Okay.
Very
And before we go
unusual.
further, for those that don't know what ablation is, let's describe what that is. Let's define that.
So ablation is with a catheter from the groin into the heart. They find the part of the heart that is not acting like it should. It either is acting as a bridge that we don't need or an area that is going off on its own. I like to call it Terrell Owens. He just wants to do his own thing. So ablation, you go with a catheter, locate that, and either freeze it or burn it.
Okay.
And the last kid I had on 4 different medications, he was 2.5 years old.
Oh my goodness.
And I talked to the doctor who does the ablations, and I said, I've got him on 4 meds, and he breaks through. And he says, we'll take care of it.
Huh.
And
So 2.5 years old, he
Yep.
had a cardiac ablation.
Yep.
So, okay. So I love hearing all that.
well, I do want to say
yes, please.
the most common cause of palpitations are palpitations. In other words, you don't have an arrhythmia.
Okay.
Okay. So of the patients referred for arrhythmias, if I have 100 people for palpitations, if I have 100 people referred for palpitations, I find something wrong with them rarely. So a lot of it is anxiety. And you can usually tease that out by saying, okay, well, when was your last episode?
Right.
Well, it was when Mom was yelling at me.
Right.
Or even
when I know
worse,
I had that big test.
I was talking to my boyfriend on the phone.
Right, exactly.
And things like that. So, most common cause of palpitations is palpitations.
Is palpitation.
The most
I like
common,
the way you say that. And anxiety is something that it's just, it's thrown out right and left these days.
Oh,
you know?
we are, I mean, COVID continues to cause problems in 2025. The loss of interaction for the kids in school is going to take years to go away, and we certainly hope it will.
My son and I were just talking about that. He went through his senior year. COVID. So
didn't get to graduate.
All the fun stuff you're supposed
yeah.
to do as a senior, but it truly has lasting effects mentally.
Oh, yeah.
And physically too. And with kids too, with COVID. And I don't know if you've experienced this being pediatricians and being pediatric cardiologists. Sorry, it's hard to get out. So with kids and the undiagnosed COVIDs. And are you seeing children that, oh my gosh, you must have had COVID somewhere along the line because this is what we're seeing now, and it seems to be an after effect. I feel like I'm hearing a lot more about that now in 2024, 2025, and I think we will going forward. Do you find that that's the case?
Well, so when we have somebody whose heart's not working well and the muscle just is not doing the job it's supposed to, and we're going, oh, what's
the reason?
I mean, his coronary arteries are normal.
Yeah.
Everything else looks normal. This valve leaks, but this is a result of the heart not working well rather than a cause. We can do imaging that will show scarring, and if there's nothing else that we can figure out and it is temporally related to COVID, then we might have the effects of myocardial fibrosis after COVID.
And that's so interesting. So I've, a decade from now, it'll be very interesting to do this show and ask that same question because there's going to be so much more that we'll know by that time. You're going to be having a tequila somewhere and resting on a beach because you should eventually retire. Hopefully I will be too. I want to talk about some structural heart defects. And very beautifully, we have ASDs, VSDs, PDAs, and interventional cath procedures. So let's start with ASD, which is atrial
septal defect.
Thank you very much.
So it's a hole in the wall between the upper chambers of the heart.
Okay, so here we go to, I'm gonna pass the toy along to you. And do we need these guys for this? No?
Eventually.
Okay. Eventually.
Yeah.
Pull these over.
So this is the upper chamber of the heart wall, and now we're looking in. There's a tricuspid valve, but this is an intact wall, the atrial septum. Now, it is extremely common for a newborn to have a communication here, but that usually goes away. But sometimes we see an actual hole. And because of the blood from the left side, left upper chamber, the left atrium, goes over to the right side, we start seeing enlargement of the right side of the heart. Heart function is still normal. And the data says that if you fix an atrial septal defect soon enough, you will have no consequence at all.
So say that again. How can the heart function still be normal? Maybe I'm missing.
There's a lot of reserve in the heart, thank goodness.
Okay.
So you're mildly enlarged. There are changes. And so, I've had, and ASDs are more common in girls than boys. That's about the only one. So I've had a teenage girl when I've diagnosed this, and I said, well, back then we need to operate on this. And of course, a teenage girl and the word operation do not go together very well.
Right.
And I tell them, look, your heart function is going to be normal afterwards and things like that. They are still very reluctant. It's a very frequent cause of a second opinion.
Wow.
Because if somebody says, well, I feel fine, and you want to ruin my bikini, they will go get a second opinion. And I've done multiple myself. And so we look at the echo, usually is all required, and we say that. Nowadays, if you have an ASD in the right position and the right size, we can close those in the cath lab without any incision at all.
Without any incisions. So you're
Nope.
going up, well, how then? Are you going up through?
Well, so usually in pediatrics, it's from the groin up.
Okay.
And so you come
So the
up.
incisions from the groin and the groin
Yeah.
mean in this area.
It's
Okay.
a needle poke.
Oh my gosh.
There's no real incision
Okay.
at all. And
Impressive.
so, and some of these are being closed in young adults and adults here in El Paso.
Okay.
So that is a step forward that El Paso has managed so far.
Mm-hmm.
Now the smaller kids, they're harder to do, and a lot of the time don't need to do it immediately anyhow. So, but it is nice because I mean, you got a lot of second opinions.
Yes.
You're crazy, doctor.
Yeah.
There's no way they need to cut me open and stuff like that. So.
Surgery with little ones is always kind of a hard one. Okay, let's move on to VSDs. And I know we have ductal artery, which is the PDAs, which you talked about that earlier, but VSDs, ventricular.
So
septal defect.
probably the most common structural heart defect is a ventricular septal defect. It's a whole
Say it slow.
ventricular septal defect.
Hi. Okay, gotcha.
And that's a hole between the pumping chambers, the lower chambers.
Okay, gotcha.
And they can run from that big to that small. Small ones in the right location, we don't do anything about.
Will the heart eventually close that, or is it just, again, non-functioning?
A lot of them will close.
Okay.
Now, when we see them down in the muscle, we say, okay, we have a very good chance. If you're up near the valves, you have to watch them.
I see.
Because with the Venturi effect, you can actually damage the valves. And even though it's a small hole, you have to go in and fix it.
Right, right.
So now, cutting edge, bleeding edge, not El Paso so far, is we can close some of these with catheters also. So it is, it's a much bigger deal. But I mean, there are places where there are no surgeons, and they use catheterization to close VSDs even near the valves.
Okay.
So,
And you were talking earlier too, so currently there are some surgeries that are being done out of town, but I always like thinking about the future of what do you foresee in El Paso with pediatric cardiology. You said the borderland is in need of a little bit more. So I always, that's the favorite part of the program for me, is what are we looking forward to here?
So in 2025 in El Paso, Texas, we are not doing any open heart surgeries here in El Paso. So if somebody needs an open heart procedure, they have to go out of town.
A pediatric open heart procedure.
Right.
Okay.
And so we're partnering with various people who can provide the best care for our kids. And for instance, for VSDs, it's simple. Tell that to the mother who gets to
Right, of
wait for
course.
4 hours waiting for their child to come out of the operating room. But it is one of our goals. You know, we would like to say, okay, well, I don't think we're going to be doing heart transplants in El Paso anytime soon. But there are a lot of things that we think that we can step up eventually and get done here in El Paso so that you don't spend 10 days in one of the big cities of Texas.
Exactly. So now you wearing the hat of Chief Medical Officer for El Paso Children's Hospital, I know that there are, there's meetings and there's more meetings and more meetings. What is that process? Just for people who are wondering, how is it that, you know, and we are, I mean, El Paso's getting so many fantastic different procedures to town. How does that start? What are the baby steps? How many meetings? Who are you meeting with? And how does it actually happen?
Well, so if we're thinking about cardiology, I've been here for 37 years. We've also, unfortunately, had 3 or 4 pediatric cardiologists come to town and leave town. So we need to have enough to get everybody seen, identify those who do need surgery, and eventually move towards being able to do something for them. There are all sorts of subspecialties in pediatric cardiology. There's the arrhythmia doctors. There are the doctors who can close the holes with catheters. There's a big one right now, which unfortunately is heart failure. There is
Heart failure in little ones, in children.
in little ones.
Okay.
So that's
That seems like such a or like a broad word, heart failure.
well, it means your heart is not able to do the job it needs to do on a consistent
Okay.
basis. I mean,
Okay.
if you we talked about perhaps with COVID, you have myocarditis and myocardial fibrosis.
And we haven't talked about that yet.
The heart doesn't work as good as it could, and so there are all sorts of steps before we think about a heart transplant. But I have patients that have, I think I've had 11 hearts transplanted
Oh, wow.
from all across Texas, and I saw one the other day. He was transplanted in Denver because he's from New Mexico.
I gotcha. Wow. Okay. That's big. And where was that procedure taking place? In Denver?
Yes, at
Okay.
Children's Colorado.
Okay. Gotcha.
Big place.
So I know that we're kind of running out of time here. I do want to talk a little bit about high-risk pregnancies, only because this, again, is a pediatric cardiology show. And in general, if we're looking at a population of mothers, you did talk about gestational diabetes, so that is a risk factor. Are there any other risk factors that we can kind of throw out there quickly so that people might think, okay, well, maybe that sonogram I should have a little bit earlier, or just be on the lookout of things? What might be some high-risk pregnancies?
Well, so the family history is probably the biggest factor. It is, this is an adult show, right? So when I get a young lady who has serious congenital heart disease and she turns, it depends on the mom, I think. She turns 14, she turns 16. Certainly by the time she's 18, I say, look, you need to recognize that you have congenital heart disease and your risk for having a baby with congenital heart disease is significantly increased. It's like 6 times the risk. Now the risk is 1 in 100, so we're talking 6 in 100. But that's a 600% increase.
Oh my goodness, right.
And
so she needs to go into her
right,
adult
and
life.
so even at 14,
Right.
and they always roll their eyes at me, and I say, and I've also got some patients who I say, you have to plan any pregnancies. You cannot just
Willy-dilly go
come
get.
onto the doorstep pregnant, because some heart diseases really don't get along with pregnancies. And we use a lot of medications that can also damage the fetus.
So in that case, when you say planning them, that they should make sure that they're in as good shape as they possibly can before they
Right.
get pregnant, so that they can carry the baby through their pregnancy, because the mother themselves, not at risk, but are having a hard time with the pregnancy.
Well,
and then
the
the baby
mothers-
also is at risk of having a congenital.
The mothers can have problems.
Okay.
I mean, a pregnancy requires mother's heart to do twice
you're
as
climbing
much
mountains
work.
all day long
Yeah.
for 9 months. Yes, I remember.
So it's, and unfortunately there are situations where we might say, you probably need to adopt instead, because we don't want to lose you,
Right.
because guess what? I know how much you want a baby, but you may
Yeah.
not get that dream.
Yeah. And those are the hard realities. I know we have a whopping 3 minutes left. Is there anything, Dr. Qureshi, that we want to talk about?
Yeah,
before
well, just
we...
a quick, what Dr. Schuster said. When we talk about like heart failure, so in the babies, when we say like a congestive heart failure, which means like simply like more blood is going to the lungs. So it's not the muscles involved. There's some more blood going to the lungs, so babies have a hard time kind of breathing because the lung is kind of flooded, with blood. So that's the thing we call a congestion or congestive heart failure. The other type of a heart failure we Dr. Schuster talked about is that muscle itself have a disease. It can be anything. It can be a virus. It can be some drugs, like those who are on chemotherapies and all that. They unfortunately can have, we need to kind of have a surveillance for them like every year to check.
Right.
Make sure that their heart muscles are okay. So one is mainly like a more of a congestion, to the lungs, and the other thing is that the muscle itself they are weak. They cannot pump that. And unfortunately, sometimes you see like a teenager, they come for like great, athletes and all that, and all of a sudden you find out, hey, they have a different kind of a heart condition. Some of them have a thick heart, we call it hypertrophic cardiomyopathy.
A thick heart, that's something
There's
too
a
that you
thick
hear
heart,
quite a bit, right?
Yeah, and then the big heart means like a big
Right,
dilated
an
one. We
enlarged,
call it
yeah.
like enlarged heart. So those are the things, unfortunately, when you go and tell them, hey, we don't know. 1/3 of them is going to get better, not completely. 1/3 of them is going to have a heart transplant, and 1/3 of them probably is not going to survive. So those are the unfortunate kind of realities. But well, that's I would say that this is when we talk about like in the realm of a heart failure. So those are the kind of little different things about that.
Well, I look forward to both y'all were talking about the future of how this is, again, research is great and everyone's in it to win it. So thank you so much for being here. Dr. Schuster, it's always an absolute pleasure seeing you out and about and then having you here on the program. And Dr. Qureshi, it was an absolute pleasure meeting you.
Thank you. Thank you so much for having me.
Thanks again for watching. This has been Pediatric Cardiology, a growing need in the borderland. I'm Catherine Berg, and this has been the El Paso Physician.
Hello, I'm Dr. Allison Days, a past president of the El Paso County Medical Society. The El Paso County Medical Society is a nonprofit organization established in 1898 that unites physicians to elevate the health of the El Paso community. We have been bringing the El Paso Physician to your home for the last 27 years on PBS El Paso. We hope that you have enjoyed this program and others we have previously recorded. They are archived on our website, epcms.com, kcostv.org, or you can also locate them on YouTube by searching for The El Paso Physician. If you should have any questions relating to this program, please feel free to email us at epmedsoc@aol.com, and we will try to have our experts answer your questions. Thank you for watching, and please feel free to provide feedback at epmedsoc@aol.com.